structure today, okay, at the end of those glands. However, they don't stay in the posterior abdominal wall. They descend, pass through the abdominal wall. You may have heard of the inguinal canal, or if not that, an inguinal hernia. All right, and which is a weakening of that wall, and they end up in the scrotal sac. So that occurs along a band of connective tissue. So you can see it on this view, sliding posterior to the peritoneum, and then into the scrotal sac. Here's an anterior view. And usually by gestational age of 7 months, they are present in the scrotal sac. So when a baby boy is born, obviously he would be born as a baby. When a boy is born, the OB or the pediatrician both will palpate the scrotal sac to see if the testes have descended. If they haven't, it's not going to require emergency surgery, but they need to descend before the child reaches puberty. If not, he'll become sterile, right, because of the higher temperatures that are present inside the abdominal or pelvic cavity. So sometimes surgical intervention might become necessary if it doesn't already occur. So this band of connective tissue is known as the gubernaculum testes. So I'm going to kind of illustrate how that occurs. There is a upper gubernaculum than a lower gubernaculum. The upper gubernaculum testis disappears, and the lower one continues to shorten. So this is the scrotum, and we have the testis. This is attached to the inferior aspect, the bottom of the sac, and it degenerates over and over in a kind of an overlapping fashion as it shortens. And as it does so, it pulls that testis down along the posterior wall, into the pelvis, through the anterior abdominal wall, and down into the scrotal sac. So eventually, this would result in a very short gubernaculum as the testis resides in the scrotum. Now when we talk about the female reproductive tract, obviously there's a lot of overlap. Okay, similar or homologous structures. So in the female, attached to the ovary, there is also an upper and a lower gubernaculum, and those both remain as ligaments that support the ovary and the uterus. So I'll remind you of that fact when we get to the female, that these are homologous structures. The gubernaculum in the male is homologous to a ligament in the female. So as it passes through this channel, both male and female are going to have inguinal canals, but the male is larger, and the male is more likely to develop an inguinal hernia, because in the female, the only thing passing through the inguinal canal is the ligament. The male had that gonad passing through, along with the vas deferens that's still there, and blood vessels and nerves. So it maintains a larger opening, and therefore that opening can be stretched, or the chapped canal itself can be penetrated by a loop of intestine. So let's look at the structure of the inguinal canal and the contents, the spermatic cord, and then we'll look at how we define direct and indirect hernias. So obviously we're no longer in the embryo here, or at least it's been circumcised. The scrotal sac is here, and it has an external layer of skin. We'll be looking at the connective tissue. And the canal is a tunnel, if you will, that passes through the abdominal wall. Right, so there's an opening between the anterior abdominal wall just above the rim of the pelvis and the scrotal sac. And that would be this space right here. So this thickening and arching of connective tissue is the external opening. And if I could grab this in my hand here, I would be holding on to wrappings of the spermatic cord. There is an internal opening as well. So testicular artery and veins, the vas deferens coming from the epididymis are going to pass into or out of that. So from the deep side, we have a deep ring. So we have a superficial opening or ring and a deep inguinal opening or ring. And the connection between the two is the inguinal canal. Now, we have a male model. Sorry, not a real person.
I'm not going to do this right now.
Here. That looks similar to that. So on this side, here is, what's the most external lateral abdominal wall muscle? External abdominal oblique. Okay? And so in cross section, his fibers are right here, but it's fascia. Remember how muscles are covered with epimysium? And then that becomes tendon when it attaches to the bone. So the tendon and fascia of the external abdominal oblique is coming down to attach to the pubic bone, and it forms these arching fibers of the superficial inguinal ring. They also wrap underneath to form the floor, the outside wall and the floor of the inguinal canal. Now the inguinal canal has been opened on this side, similar to on that diagram, and so you're seeing the contents of the inguinal canal, and up here at the top would be where the deep inguinal ring is. It's already been opened, so the concept of that as an inguinal ring can be difficult to recognize. So let's move over here to this model. You may not all be able to see it, but from this view, here's the aorta, okay? And it gives rise to a branch that's going to give blood vessels to the pelvis and move into the lower extremity. And here, this yellowish brown structure right here is the vas deferens. And it passes to the anterior abdominal wall and disappears. And that's where the deep inguinal ring is. All right, on the inside, on the deep surface of the anterior abdominal wall. The rest of that is covered by skin. So let me move ahead to another image of that deep surface of the anterior abdominal wall. And here we go. So here's the inside of the anterior abdominal cavity, Here's rectus abdominis. Here's transverse abdominis muscle, which is the deepest. And here's the vas deferens, testicular artery and vein disappearing or coming into the cavity. And that opening right there is the deep inguinal ring. Okay? So when we have a hernia that we'll talk about in a few minutes, we can have a weakened muscle area right here where the obliques are the linea semilunaris, where the obliques meet the rectus abdominis. And that can be weakened, and we can go into the inguinal canal that way, or we can go in through the ring. Right? That creates the hernia. But let's take a look at the structures that form the wall of the inguinal canal. You have this diagram on page 50. This is from Netters. All right, and it provided me the clear, because I've always had difficulty, or students have always had difficulty understanding these layers because they're offset from each other. It's not like you could have a tunnel when I say a canal or a tunnel with various walls, individuals would think about, so we have a building block, and it has an arch like that, okay? And you have a whole series of those, and you would have a tunnel. That's what we've done here, except those structures are offset slightly. So we are going anterior and medial. My perspective here, somewhat to be desired. So if something's going to pass through here from deep to superficial, it's going to come at an angle. All right, so you take these wooden blocks and set them up. It's not a straight line, it comes at an angle, or it leaves at an angle. So here is the spermatic cord. This is vas deferens, testicular artery, testicular veins. And it's passing into the inguinal canal, or out of, depending on which structure we're talking about. Here's the superficial inguinal ring. And as it passes through this, here's where it comes out. And there's the vas deferens. So this is what is opened in that previous image of the inguinal canal. So the layers of the inguinal canal are given on page 50, up at the top. You don't have to know all of those, but let me emphasize the ones I do want you to know. So the superficial ring, right here, and on the model, this, not the cut one, but up here, all right, this tissue is made up of the fascia, or the connective tissue, of the external abdominal oblique. That fascia tendon, if you will, comes down and wraps over, forming the roof of the inguinal canal, the floor, and then has the opening in it for the superficial inguinal ring. That fascia is identified as the external spermatic fascia. So remember I said that in this portion of reproductive, I'm going to talk about what develops from what, or what has the origin. And so vas deferens has its origin from the mesonephric duct, and epididymis has its origin from the mesonephric duct. So here we have the external spermatic fascia has its origin from the connective tissue of the external abdominal oblique. Okay? Everybody with me on that? Then slightly deeper, what's the next muscle? Internal abdominal oblique. All right, so as we follow this muscle, the muscle itself arches over the spermatic cord, the vas deferens and its blood vessels. Not only does the muscle arch over, but it gives some of its muscle fibers to the spermatic cord. Skeletal or smooth? Skeletal. Internal abdominal oblique is a skeletal muscle. All right. So these fibers are known as cremaster muscle. Skeletal fibers. And they have their origin from the internal abdominal oblique. And they wrap around the spermatic cord. And that would be these pink lines right here. Those are referring to the cremaster muscle fibers. So the external spermatic fascia has already been removed. All right? see right here. The next layer is the transverse muscle, transversalis abdominis, and the transversalis fascia. We're not going to worry about those. Okay, you don't have to worry about those. The next layer is the peritoneum. Now, the testis, as it moves into the spermatic cord, actually pushes through and takes these layers with it. So it's like I had sheets hanging over a clothesline, so I don't see that anymore. But let's say as I walk through them, I'm pushing them in front of me. So now I'm kind of forming a pocket. And I have the first sheet, and then I walk into the second sheet, and that's completely surrounding me. So as the testis is moving through these layers of the abdominal wall, it's taking it with them. And so it's completely surrounded by all of those. But remember, it was behind the peritoneum. It's not going to be in here and push through the peritoneum. It was behind it already. So think of the testis sliding down the posterior abdominal wall, and as it reaches the opening to the inguinal canal, anthropomorphic, it reaches out and it grabs a piece of that peritoneum and pulls it down with it as it slides down into the scrotum. So that piece of peritoneum is going to be only in the anterior aspect of the testis rather than completely surrounding it. So what I'm describing, I'll draw it larger, is here's the scrotum, and the testes pulls in a layer, and it pulls another layer in, but the peritoneum is only in front. Okay, think about grabbing it, it's a double layer, because it's pulling it down into that opening, but it's only in front of the testes. So that becomes a layer, a double layer known as the tunica vaginalis. So you guys have mixed out. You actually have a vagina. You have two of them. I've never gone to the, what are they called? The monologue, the vagina, something or another. Well, I don't know if she talks about vagina envy, but anyway. Vaginalis just really means that invagination, a formation of an inward sac. So here are the layers that I've talked about, and I'm going to diagram them on the board with you because you don't have this diagram in the lecture notes. And talk about, this would be the space in the scrotum where the testes is and the layers of those components. Right? So I'm going to include these and diagram this in a fashion similar to that. So the black line is going to be the skin of the scrotal sac and the spermatic cord wall. I just kind of shortened that wall. Skin. Right? So we're looking at this structure right here, okay, of the scrotum. And the upward component here has just been foreshortened, maybe a little bit short. Now, within the skin is a layer of smooth muscle, the deep part, the deep layer of the skin. And this is smooth muscle, known as the dartos muscle. When it contracts, it wrinkles up the scrotal skin. Its function is to help just keep the temperature of the testes from getting too cold rather than too hot. This is smooth muscle, so it's under autonomic control. And that's this yellow line on the diagram. The next is the external abdominal oblique up here. But remember, that muscle doesn't extend into the inguinal canal. Only its fascia does. this layer would be the external spermatic fascia. This would be the internal abdominal oblique, and its fibers do completely extend into and surround the testis. And this is the cremaster muscle. And then this would be the transversalis fascia that's shown, which I'm not going to include. And so we'll go to the green line, which is the peritoneum. You guys remember the definition of a serous membrane from Bio 430? The simple squamous epithelium that lines the body cavity and secretes a watery fluid. So in the lungs we have the pleura, around the heart we have the pericardium, and in the abdominal cavity we have peritoneum. All right?
Right.
Parietal attached to the body wall. Attached to the organs would be visceral. Correct. So this is a serous membrane that's attached to the abdominal deep surface of the abdominal muscles. And remember, it comes in only on the anterior surface. It does not completely surround the testis. So I'm going to write the lettering in black because the green isn't showing up very well, but this would be peritoneum. And here it forms the tunica vaginalis. And that would be this structure here. Typically that's a collapsed fold or sac. It can become filled with fluid. And in that case, it expands and creates a swelling on one or both total sacs, known as a hydrocele. It just needs to be drained. All right. It occurs you see it most often in young children or even infants. So the hydrocele can be spelled a couple of different ways. The more British way is with that way. Here's the way it's spelled on the slide. So that's just the fluid-filled tunica vaginalis. Hydro meaning water, cele referring to sac.
But what causes it to fill with something?
It can be, well, what's happening is the serous fluid, the peritoneum is excreting a serous fluid. What triggers that is often an inflammation, or it may be that it's not completely collapsed. There may be extra vascular supply to it, or it may have an opening to the peritoneum wherein the fluid of the peritoneal cavity drains into it. In other words, I don't really know each time. There's a possible cause. So again, this is in Netter's. It's page 250, plate 254, I think. Now, back to this picture, there is a blood vessel that comes off. This is the external iliac that's going to become the femoral blood vessels. And just prior to the anterior abdominal wall, the inferior epigastric vessels are formed. And the reason I mention that is that it helps in locating and identifying the two different types of hernia. So here's the anterior abdominal wall, and here there would be another one over on this set. These are known as the inferior epigastrics. They just supply blood supply to the anterior abdominal wall. But if we look at the deep surface of the anterior abdominal wall, here is that vessel, and I'll write it on the board. And you can see that the deep inguinal ring is lateral to the inferior epigastric vessels. All right. So if this is our right side, here would be the deep inguinal ring. And these would be the inferior epigastric artery and vein. Deep inguinal ring. So why is that important? Well, there are two types of inguinal hernia. The hernia is a weakened condition of a muscle. So usually allowing an organ to protrude through that. A hiatal hernia, for example, is a weakness in the opening of the diaphragm around the esophagus. And the stomach can push up into the thoracic cavity through that, or the fold of the intestine. And of course that then compromises how much the lungs can expand, or the heart can fill with blood. Some babies are born with an umbilical hernia, a weakness in the region between the two the rectus abdominis muscles. And so especially if they cry a lot, that can cause the umbilicus to stretch open, and you can have a small couple-inch diameter high mound of intestines pushing through that for the infant. So an inguinal hernia is a weakness in the muscle wall that might be congenital but exacerbated by heavy lifting, anything that increases intra-abdominal pressure. And there's two ways for the intestinal loop to penetrate and end up in the inguinal canal. Either type of hernia, it can end up in the inguinal canal. The direct inguinal hernia goes straight. It would be medial to the inferior epigastric. It goes straight through this weakened layers of oblique muscles and fascia and ends up in the canal. The indirect goes through the deep inguinal ring. Now to me, that was always confusing.
Sounds backwards.
Yes, it does, because it seems like the most direct route would be the easiest. Think of direct as the straightest. All right, if I'm a loop of intestine, the straightest route, most direct route for me to get out of this building is to just go right through here, bulldoze my way through the wall, and get outside. It's going to take longer if I then have to make a right-hand turn and then make a left-hand turn to get out the door. All right, so that's the indirect route. It's not the straightest. So the straightest is just to plow right through. You can only do it because this wall is weakened.
Where does it go through when it's direct?
It goes through the abdominal muscles themselves, the obliques. All right, so if we were to go back and look at the diagram here, the direct is going to do this. It's going to come straight through all of these layers and end up in the inguinal canal. Notice that that is medial to our inferior epigastric vessels. The indirect is going to come through the deep inguinal ring, still end up in the inguinal canal. The problem with both is the increased likelihood that as the intestines are twisted and compressed, there's the lack of blood supply and gangrene that can develop, as well as intestinal blockage.
Can this happen in boys and girls?
It's more likely to occur, it's not as likely to occur in children, unless it's a truly congenital condition, typically see it in middle-aged men that don't have very strong abdominal muscles and lift things without using their knees. You know, just kind of bend over and lift straight up, or have a lot of problems with constipation and straining at the bowels. And the intestine may not permanently stay in the inguinal canal, it may only appear under pressure and then disappear when the pressure is over.
I'm just gonna ask, so